Hello all. This is an unedited video of endoscopic sphenopalatine artery ligation. My name is Dr. Paresh Naik, and here we are seeing 52-year-old gentleman who presented with recurrent unilateral epistaxis. He had three massive episodes in less than 12 hours. So just to remind you, this is an unedited video. So this is how real time it will be. The moment I go inside, the first thing I see is nasal hair, lot of nasal hair. This can be annoying and disturbing for endoscopic surgery because the vision gets obscured. You can see how everywhere there is nasal hair. Many times in elective cases, I ask my patients to do nasal grooming. I wanted to see and have a good look if I could see any bleeding point or any congested vessel which is popping out. So I prefer to use Freyr's elevator than a suction because Freyr's elevator is atraumatic and you can have a gentle look without causing trauma and try to go inside. This allowed me, this is how I go. I press the inferior turbinate away and see if there was anything. There is no bleeding whatsoever you can see. So most probably the bleeding source is from mucosa. And although his blood pressure was normal, he is not seropositive. Because of some reason, this patient had it. Now I could see some congested spots. But again, I was finding it difficult to get a good entry because of nasal hair. So I decide I need to take the nasal hair down. People have trimmers. What I prefer to do is just plain scissor, and with the scissor use some ointment so that the nasal hair they don't fall inside in the nasal cavity. So trimming the nasal hair, that is what I prefer. Meanwhile, before I'm doing that, I thought let me decongest the whole nasal cavity. And in such cases, I don't prefer to do blind nasal packing. That's why an EUA, that is examination under anesthesia, is good. I use 1 in 10,000 adrenaline. Many times people prefer to use Moffat solution, but I just want to avoid cocaine because there's a lot of litigation, signing off, and preparation. And the effect of 1 in 10,000 adrenaline is almost same as Moffat solution. Ideally, it's good to keep the patties for at least 5 minutes. Many people advise that we should rub on the mucosa. But what I felt or my experience was whenever I rubbed on the mucosa, the patty or merosil, which is dipped in adrenaline, it the traction or the friction would congest the nasal mucosa more. And in endoscopic nasal surgeries, most of the bleeding is from mucosa. As I said that I am using scissors and scissors to trim the nasal hair. The other thing that one can do is use a trimmer, and that is quite quick. But many places they don't have the nasal trimmer, and also the sterility we want to check. So in this case, I do want to clear the nasal hair, and a good view will be achieved. We are going to pass multiple instruments, and that way it will help us to get a good view. In any surgery, we want to have a good view, then good exposure and good lighting and good positioning. So exposure, light and position. So many people ask during any endoscopic surgery, what should be the ideal blood pressure? I ask my anesthetist to give me a low blood pressure. Many times it's not possible, so at least I ask them to give me a normal blood pressure. Most of the times with slight head elevation and decongesting the nose with adrenaline, it helps us to get a good hemostasis. Most of the bleeding, as I said, is going to be from the nasal mucosa. As you can see, just by decongestion, you can see good nasal anatomy. You can also place in merosil. What you can do is take a big long merosil, cut into 4 or 5 pieces, dip it in with adrenaline solution and place inside. Place at few places in the first pass, second pass, and between the middle turbinate and the septum. Now, as you can see, most of the area is well exposed. I cannot see any lesion which can cause bleeding. The anterior part of nasal cavity is also now clearly seen. This is the Rubina Karl-Storz endoscopic system. The Karl-Storz endoscopes are very good. They are very clear and they are actually high definition.
So just trimming the nasal hair to make the access easy, and we don't want any hindrance. From this point, I'm going to start playing some background music so that you don't get bored. So after prepping the nose, giving a wash and decongesting, it's time to infiltrate. Many clinicians do not prefer to infiltrate, it's a personal choice. This is what it happens. While infiltrating, the inferior turbinate comes in way. It's most of the time it happens. So you need to lateralize it. Lateralization over here is mainly for the access, and so that your instruments can pass in that second pass, in the corner, in that part behind where we want our instruments to reach freely. So what I feel is, over a period of time, I have learned infiltration not only decongest, but it helps me to elevate the plane. Now there are two ways of doing the sphenopalatine artery ligation. One is you can do a complete middle meatal antrostomy, and the other one is a direct by taking a flap. So this is an infiltration. You can see how there is direct blanching. One must take care while infiltrating that you are not hitting a vessel directly. So you palpate. I usually prefer to palpate with Freyers before, and also with the needle you can palpate and see. Many times you can miss the spot and go in the maxillary sinus. That is fine. If you are going in the maxillary sinus, then you know where to go next. It's always better to go in maxillary sinus than hitting one of the arteries. Use a dental syringe or a spinal needle. Once infiltration is done, I use a patty. This patty again is with adrenaline, and I place it exactly where you're seeing. This thing not just decongests the area, but also separates the middle turbinate from the medial wall. It gives you good access, and that's how it helps us to advance further step by step. During EUA, I saw a congested vessel at the anterior part of the septum. So it's always better to cauterize it. If the patient is having multiple episodes, we do want to be slightly aggressive so that they don't have repeat episode. So this is the spot what I was talking about. Even after decongesting, you can see that congested vessel popping out. You can use laser, you can use coblation, you can use bipolar. If you're using bipolar, go on a low mode and always check with your scrub team what is the temperature of the bipolar, what voltage it is on. Then once we know it, use some fluid. The bipolar will act if there is fluid between two prongs, and if there is some fluid between two prongs, if the mucosa is wet, it acts very fast. So that is good. Whenever you use bipolar, we have to be sure about two things. Number one, it is not touching the nasal skin on the vestibule, columella. The other thing is that after the procedure, we use ointment. This actually helps in healing. Also decreases the chances of crusting. It moisturizes the mucosa. That's the thing. We usually refrain from using monopolar. Monopolar is can cause localized trauma and also localized devascularization. It can also penetrate, and it is not usually controlled. Here it is very controlled. One more thing that we would have experienced is monopolar sticks to the mucosa, and when we are pulling out, it erodes the mucosa again. Many clinicians also use silver nitride sticks, and also many people they use. It's a clinician's choice. You can use laser, you can use coblation. I did something controversial. I also cauterized, bipolarized the turbinate. The turbinate looked congested in before, and also one says that two adjacent surfaces should never be cauterized because there's a chance of adhesion formation. Post-op, there was no adhesion, mainly because of use of ointment and nasal care, and I had a close watch on the patient. Once the area is decongested, that is our target area. You have to make an incision and take the flap. The incision can be using sickle knife or Cautery salivator or 15 number blade, or even we have got keratome, the ophthalmologist use. If you ask me, it's for me the best that works is Cautery or a sickle knife, but the sickle knife has to be sharp. So we have to elevate the flap. You need to palpate, and don't be afraid or don't worry if you go into maxillary sinus. It happens. When I start my access to the sphenopalatine artery, I usually tell my anesthetist that I'm going to go access over there. This helps him to control his heart rate and blood pressure. The patients, I mean. Because if it is controlled, it gives me a good access and less bleeding. If there is any bleeding, the bleeding is not forceful. So all I have to do is go inside and identify the vessel, cauterize it. Many people clip it. I prefer to cauterize it and cut it. So it's not basically an sphenopalatine artery ligation. It is more of a sphenopalatine artery cautery. Using the sickle knife. Now look at the sickle knife. I prefer sickle knife, but it is just okay sharp. I want it to be sharper than this. The thing about this incision is, if the ideal incision is just few millimeters anterior to the crista, although it is difficult, you can come very anterior. You should not try and come beyond half the length of the middle turbinate. So you understand, from behind, not more than half. Then you might enter in the maxillary sinus. Once the incision is made, you can expect some oozing. This oozing will be definitely less if it is already decongested and infiltrated. Again, with the infiltration, we know that there is going to be a plane which gets created. Keep on using patties. You can use saline soak patty or adrenaline soak patty. I prefer adrenaline every time. And whenever the patty goes in, I inform the anesthesia team. Because always they'll be like, why the heart rate has gone up? You should have told me. I would have controlled it. You don't want all those things happening. I'm a pretty calm person in the theater. I like peace, maybe music, but no, there should not be miscommunication, or there should not be yelling and shouting. So as the patty goes in the flap, you can see bone, and that's your sweet spot. Many times you can see crista. If there is crista, we have to take it down using kerrison or a drill. Depends on what you are comfortable with. Keep on using the patty. Patty forms a protective layer between your instrument and dissection. So it is non-traumatizing. Also, what patty does is it absorbs the blood so that it doesn't come in your way. The capillary action of the patty directs it down. One more thing what I like to do is, once the patty is over there, use a small size suction and you can help to elevate. You're not traumatizing the mucosa. The mucosa doesn't come in the sucker and you can freely go inside. This helps in a very good dissection. I use this same method for elevating head flap, also for elevating some flaps for septal perforation repair as well. So this is very nice. I like it, and for some reason I prefer this method than using suction elevator. Whenever I use suction elevator, the endoscope screen gets blurred with the blood. I don't know whether you guys have observed that. The suction pulls the blood, it draws the blood to yourself, and not everything gets absorbed now, and some of the blood comes on the endoscope. Once the suction is done and you have a good sight, you can go inside, elevate the flap, go all the way inside, and till where are you going? You are going till you see that angulation where the sphenoid is seen, the curvature is seen, and just above that is your area. The moment you go over there, we have to use blunter instruments. You can use ball probe or use the other side of the Freyers, more blunt. You can use suction as well. And keep on using patty. This is very good field, I must say. The heart rate all this while was around 50 to 60, and the blood pressure was well under control. It was in double digit, both systolic and diastolic. This actually helps us a lot, and I am blessed to have a good anesthetist, and usually if the anesthetist is good, it helps a lot during the surgery. Once I was doing a craniopharyngioma, and it was a new anesthetist, and sorry to say, but not very well versed with use of topical adrenaline. And when I was using it, the whole procedure, the blood pressure was ranging from 160 by 110. Raising the Haddad flap was so difficult for me, and not only that, it was continuously oozing, and craniopharyngioma during dissection also, it was continuously oozing. Whenever there is always some kind of ooze when we take the sphenoid mucosa out because of the inflammation. So it's a blessing to have a good anesthetist. Using again sickle knife, trying to dissect and go hugging the bone so that we go or hit that sweet spot. Now remember, this is completely unedited, so there are a couple of things which you might feel controversial, but as I have gotten used to the method, I don't like to change instruments. Many times changing the instruments waste a lot of time, and that's why if I'm comfortable, I carry on with the same instrument. Over here, for example, the last maneuver I should have done with ball probe, but I continued with sickle knife. Again, keeping the patty, it's quite annoying, it can be frustrating, you require a lot of patience, but it helps actually. And we think we are going to waste a lot of time, but as you can see, the whole procedure finished under 40 minutes, and that's not a bad time. Use the patty. Later on, you can decrease the dilution of the patty. You can decrease into 1 in 50,000 or even in 100,000. That is 1 in 1 lakh. And go inside. The more you approach, the better idea you get. In this kind of case, I was slightly lucky to have no crista. If there was crista, I would have punched it out. Previously, I uploaded a video in a young girl where there was crista and I had taken the crista down. You can see there is a fold or an attachment at around 11 to 12 o'clock. The whole mucosa got separated very easily from the bone, except for that point. Can you see just above the suction? That is where the sphenopalatine artery is coming out from. And be cautious. If it is not coming out, don't force it, or else you may cause tear and everything will go off. I tried to elevate the mucosa of the maxillary sinus just to make sure that we are on the right plane. At times, if you think or if you're doubtful, you can open the maxillary sinus and trace the back wall where you can see the impression of the vessel coming out. But this is what I have learned. If any kind of mucosa is finding it difficult to come out, do not force it. There might be a branch which is holding that mucosa. There might be something which is holding the mucosa. I did something orthodox over here. This is not usually what I do, but I did it anyway. I took that ledge out. Why did I do that? Because I wanted to get a better access. You can do that with a lux forceps, or you can drill it out. Drilling is good, but I did not want to open the drill just for this one step. So I was like, okay, fine, I can adjust. That is not a problem. This is one thing I wanted to show you. Can you see the whole big line? It's a tear. That tear happened when I was taking that piece of bone out. And that was something that shouldn't have happened. Should have been slightly careful while taking out. Now you can see the sphenopalatine artery coming out of the foramen. So whenever you are taking any bony piece out, and if it is quite large, make sure you're not hitting any mucosa. Now this is a tear which has caused, if you ask me, this is introp morbidity, introp minor complication, which was not supposed to happen, but it happened. Using a ball probe, I tried to bring the sphenopalatine artery forwards. Why do I want to bring it forwards? Because it's a very, very, very chunky vessel. This artery is so chunky that you have to cauterize multiple times to make sure that it is completely cauterized. You can use endoscopic bipolar or even the normal bipolar. It depends on your comfort. In endoscopic bipolar, what happens is whenever you use bipolar, you have to again clean it. I'm using handheld bipolar. In certain cases, it is good going inside and cauterizing it. Whenever you cauterize, after that, you have to suction it. Make sure there is some fluid between the two prongs. Any kind of bipolar. If there is no fluid, the mucosa will get stuck, and when you're coming out, it will tear the vessel. It will pull the vessel out. And that kind of bleeding is very painful. There is a company called a Sutter. Sutter's bipolar are good. They are non-sticky ones, but it's quite expensive, but they are very good. You can see now more and more you can start understanding it's a big vessel. Step by step, cauterize it. We had one case in which we did cauterize and just left it. However, the patient started bleeding at the same night. And when we took the patient in, it was that vessel which was not completely cauterized. It was looking charred from outside. So we get an impression it's completely charred. It's fine. But however, the posterior aspect was not. So since then, I started cutting the vessel. Now, when you're using bipolar, many people say that it is quite aggressive method and it can affect the nerve supply which is coming just posterior and can cause dryness of the nasal mucosa. Well, that's correct. But my answer for that is, what is better, having dryness or someone who has bled at least 3-4 times, including at night, choking, in social event? Which one is better? There is always a solution for dryness of the nose, right? We can ask the patient to use some moisturizing cream, Vaseline, but controlling bleeding is slightly important. And in such kind of cases, especially the patient is on aspirin and blood thinners, multi-vessel disease, stroke, I think it's better that we should go aggressive. because we cannot stop those medications. You can see I'm using a scissor over here and trying to cut. I'm not going to cut completely. I'm going to cut layer by layer. Once I have cut, there is not much oozing. That means it has slightly cauterized it. I go again and cauterize again. This kind of step, it requires slight patience. We become very impatient, and I was like, and you feel, I want to do it then and there. That's it. I want to cut it. But no. What we have to do is go slowly, steadily. Go inside, cauterize it, suction it, maybe give a wash, cut it again, see how it is. Use endoscopic scissors if you want. It is getting charred, but can you see that vessel is still chunky? This gives an impression that the vessel is completely cauterized, but this we will come to know only once we cut it. Use fluid, and whenever we cauterize, the vessel shrinks in size. It gives more and more area to go inside. Many people place a Merosil pack at the inferior aspect that keeps the flap away. Many people like to use some other maneuvers. It depends. You can always modify. You can learn from other surgeons and see which is the best for you. We are using Savlon as anti-fogging. Many people, they use anti-fog. Many people use hot water. Keep on giving repeated wash. You can use any temperature preference, that doesn't matter in this case. Wash clears the debris away, and again keeps your field quite nice. And use a bipolar. Many people find it difficult to use bipolar over there. So what I do is I put a small finger in between the two prongs, and I go inside and elevate it. This is the place where we want to dissect it and cut it and open it up. Whenever you're using bipolar, we have to use suction. You can use suction, keep the suction in the other nasal cavity, or just keep it at the entrance of the nostril. I was slightly impatient over there. I just wanted to go ahead and cut it, but then I realized no, there is no point. I need to see how it is. And that's why I went in with the suction and cleared it. Going inside using endoscopic scissors, I cut it. I separate it. I cut it and separate it. Till where do I go? Till that curvature. All that turn that you can see, because there are vessels which are coming out and branching. And there are certain branches which get branched before the foramen, and they come out separately. Once it is again dissected, I'm going inside and cauterizing it. As you can see, I'm being slightly aggressive. The patient came for follow-up 2 months, 3 months, 4 months. I followed the patient for like around 5 months, and there was no post-op bleeding, and the patient was very happy. The family members were happy. They were happy that they don't have to wash clothes again and again. The tear part, here's the tear part which had happened, now getting cauterized. And after the surgery, I was more worried about the tear, that what if that bleeds? What if causes septal perforation? But usually what I've noticed is when there is a tear or cautery used on one side of a septum, if it is low voltage, so I keep it at around 10 to 12. It doesn't cause perforation. It can cause adhesions. So if there is overuse, I put a splint inside. But for perforation, you need to go very high, beyond 20. Then there is a good chance. But usually the other side of flap or surrounding mucosa takes care of it, unless and until the patient is very unlucky, or the patient is using constantly decongesting agent. Overall, you can see just by topical decongestion how a very good feel you're getting. Once you're satisfied, you can also cauterize the septal branches, which come medial to the middle turbinate and slightly lateral as well. Many people say that there is a bleeding from the palatovaginal canal, so you need to cauterize that as well. So for that purpose, it's better to cauterize on the medial aspect of the middle turbinate. You can see it's quite clear. I am satisfied. You can see how bushy the other side nasal cavity is. We have trimmed on this side. That's slightly injustice. We should have done on both sides, but we can't keep on grooming everything. Again, cauterizing, making dead sure that everything is fine. And you can place after this some Abgel or Surgicel as per your wish, or a nasopore, anything that is dissolvable. As I said, on the medial aspect, just turning the turbinate laterally, cauterizing that area. That is another area that we should take care of in case if someone is having torrential repeated nasal bleed. We are almost done with the procedure. It is time to inform your anesthetist that 10 minutes more or 15 minutes more for the surgery to get over, so that they start prepping. They don't want to give more and more anesthesia so that they don't have difficult recovery. Cauterizing the aspects, whatever the congested area I was seeing or the injured sites because of the bone piece coming out. Cleaning the area, giving a lot of wash, and last bit will be putting some antibiotic. I'm putting a nice sheet of dissolvable Abgel over there, which is sitting over there. What happens is Abgel comes in contact with blood and it forms a glue kind of area. This also gives some pressure, and if there is overnight bleeding, it takes care of it. You don't need to rush immediately. What kind of bleeding can happen? Well, weaning off of anesthesia. Weaning off of anesthesia can dilate the vessels. If there is small branch over there, it will start oozing. If the mucosa, remember we have used a sickle knife, and that elevated flap we have not cauterized. So that kind of area can ooze. So for that purpose, I use some Abgel. This is the ointment. Can you see it's coated with an ointment? I'm putting it on the other cauterized area and in the nasal cavity. What ointment to use? Whatever is convenient for you. Just make sure that Naseptin should not be used in cases of people having peanut allergy. Here I'm being slightly paranoid and buzzing off whatever looks red and congested. So yeah, this is again ointment, putting in the nasal cavity, making sure that it's getting healed well. After the surgery as well, I advise patients to do this as a follow-up. That will be nasal douching followed by ointment. Do it 2 to 3 times a day, so that nasal douching will take the crust away, and again you put that ointment on the fresh, nice mucosa. We are done with the surgery. Last bits and pieces. I have not used Merocil in this case because it can cause trauma while taking it out. And also, if the patient bleeds, I want to know that the patient bleeds, not like, it keeps holds over there, and after a lot of time when there is a lot of blood loss, I come to know. Thank you for listening to this and watching this video. This was a completely unedited video, and as you can see, the whole surgical procedure was around 34 minutes and 3 seconds. We always suction the choana, and once that is done, take the throat pack out, and if asked the anesthetist, and then hand it over. Thank you. Please do share with your colleagues.